Thank you for your kind invitation, Rebecca. And you asked me to talk about Moberg and his principles. And that actually gives me a great pleasure because I'm a great fan of Eric Moberg. So the question was, are his principles still valid? Well, for those who don't know him or who he was a Swedish surgeon. He retired at age 65. He felt like he was forced to retire, wasn't happy with that, and he had already gained interest in treating tetraplegic patients. And so instead of going back to his sailing and countryside house, which he still did, he decided to try and gain interest and help those tetraplegic patients in order to gain more function. And this is quoting his words: "The upper limbs are, after the brain, the most important remaining functional resource, and the most important to them, as Jan just told us." So what he did is go into rehab centers and interview patients and look at them act in their activities of daily living and environment. And he pretty soon found out that one of the very important resources for them was the tenodesis effect of the wrist. So that's a patient whom we would call an IC5. You see that he has some FCR, some wrist flexors. He has wrist flexors and wrist extensors, and that's all he has. He has no active function in his fingers and thumb. And yet, you see how he can grasp and pinch just with that tenodesis effect. And so he rightly thought, this is where we need to get started. And probably when you look back at previous literature, there was a lot of failure, and that's because this wasn't taken into account. And some people tried to restore grip or grasp and didn't turn out to be very successful. So that was one of his primary goals. And he published very early on. He published his experience in 1938 in what remains a key part of our literature, a little booklet, very thin, termed "The Upper Limb in Tetraplegia, a New Approach to Surgical Rehabilitation." And in this little book, he states that the goal of surgery is, 1, to construct an elbow extensor, and 2, to create a single hand grip. At the time, by a single hand grip, he mostly meant a key pinch between the thumb and the index finger. His second thought regarding elbow extension was that it is worthwhile to strive for reconstructing elbow extension even if nothing can be done for the hands. And his idea is that it prevents shoulder contracture. It is very helpful for activities in bed. And we all know about the patient who has his elbow flexed and just cannot push the blankets away or just bring the blankets back. This makes a whole difference for the night. And just that, it is worth doing a lot. And also for activities in wheelchair, the reconstruction of an elbow extension is really worthwhile. Okay, is this still valid? Well, we must remember that he was mostly acting with higher levels of tetraplegia. This was the group of patients he decided to work on. And obviously, I think we still all agree that in these higher groups, we need to reconstruct elbow extension, whatever means we use, and that we need to create a grip. So that was his way of performing those surgeries, either reconstruction of elbow extension with posterior deltoid to triceps, That was his preferred choice whenever this was possible. Sometimes the posterior deltoid is not strong enough in the very high groups, but he preferred that over biceps to triceps because he felt it was important to keep the biceps intact. He also was extremely descriptive in the post-op rehabilitation after elbow extension reconstruction. And I think that this made a big difference because there had been prior trials. In France, Maire d'Aubigné had tried to do this kind of reconstruction. But they, early surgeons, tried to mobilize the elbow in the full range after a period of immobilization. And a lot of this ended up in a slackening and a lack of the last degrees of elbow extension. And this has been probably a very good move forward. This is following Moberg's principle. Patient 4 months after post-deltoid to triceps on the right side and 8 months on the left side. That was his way of reconstructing grip that he called the key grip pinch or lateral pinch. And that's his actual drawing and showing restoration of active wrist extension by means of the brachioradialis, tenodesis of the flexor pollicis longus to the radius, and thumb IP joint stabilization. As you can see, he used to do this with a K-wire and leave the K-wire in for as long as needed. I had the personal experience of one of my patients coming back after 2 years, and the thumb was a little flexed, and I said, "What happened?" And he said, "Well, nothing." I said, "Well, wasn't there something in there?" He said, "Oh yeah, that thing. Yeah, I took it out." So from that day on, I decided there was probably better solutions, and ever since we did find better solutions. So instead of doing K-wiring, we have been turning to different solutions like tenodesis and the so-called New Zealand tenodesis with the FPL has proved quite effective. The ways in which we may not have been following all the way through to his principles is by paying more attention to finger and thumb extension. And I think in the time there was little emphasis on extension, and I think that by thinking more about it and acting more towards extension, we have been able to help our patients even more. Of course, the whole new field of nerve transfer, which was not available at the time, has helped us in that direction. And I wouldn't say that we haven't followed its principles. I would say that we have augmented them with our new possibilities. Slowly but surely, this new concept started to spread. And there was a very important meeting in France, actually in Gien in 1984, where the few pioneers of that field decided they needed to have a common way of classifying these patients. And Moberg was a great actor of that classification. Actually, for those who were there, and Rod Hance was and gave me the story, there was a huge battle between all these people, and mostly between Moberg and Zancoli, who had very different ideas about the classification. Zancoli actually wasn't going to come, but flew from Argentina. He made a 3-day trip just to be there and push his way, but unfortunately, it was more Moberg's classification that took over rather than Zancoli's. But doesn't matter. Anyway, so this classification was putting emphasis both on the motor and the sensory part of the evaluation. And so the motor part was according to the lowest key muscle that was at or greater than MRC4. And you can see here the result of this classification. And the sensory part, and that was pretty much Moberg ideas, that we needed to have good enough two-point discrimination for the sensation to be helpful. And the classification involved two groups, the O group, where the two-point discrimination was greater than 10 or 12 millimeters, which was not very satisfactory, and then you needed to be cautious about decision-making for surgery. And the CU group, where the two-point discrimination was lower than 10 to 12 millimeters, and then it was safer. So is that still valid? Well, the motor classification, more than 30 years later, is still being used and hasn't changed a bit. We all know many classifications which have been modified by such and then remodified by such. This one has remained the same for all these years, and that's, I guess, self-proving that it's really a useful classification. I would say that on the sensory component of the classification, many of us don't use it so much anymore, and we could discuss that. And the reason why is that when you get to the groups where surgery can be done, and group 1 maybe not all the time, but from group 2 down, sensation is enough, that it's not usually, at least in complete patients, too much of a problem. So this OCU classification probably remains important for group 0 and group 1 patients. Some other of his principles were stabilizing the elbow before using the brachioradialis. And the brachioradialis being a B-article muscle, becoming a B-articular muscle when it's transferred, especially to the thumb, you really need to have elbow extension stabilization, because if you start to motorize your brachioradialis and it's unopposed by an extensor, then it's likely that a good deal of the force exerted by the muscle is going to be used proximally instead of being used distally. I don't think anyone opposes this principle even nowadays. Another one of his principles was that opposition was not a goal of surgery in tetraplegia. This is his words. He said it's not to pick up small objects, but to obtain a grip that's useful for holding a fork, dressing, undressing, using cassettes and books. Maybe we can challenge the cassettes like John did earlier, and the books. But his belief was that we needed to have key grip, and that was the most important thing. Well, should that be challenged? Probably so, and that's because, again, we have improved our techniques. We are standing on the shoulders of people like Moberg, and from there on, we can reach further and maybe offer to our patients some more sophisticated types of grasp and pinch. Again, finger extension is something that he didn't pay much attention to at the time, and it has become very important. And also, the intrinsics, dear to Jan and to myself, are something that is important to consider when you are restoring some strengths in your finger flexors. One of his basic thoughts was that you should never jeopardize the strength of wrist extension. I don't think that up to this day nobody has ever questioned this. This is extremely important. This has remained one of the fundamental principles in this surgery. Whether we use tendon surgery or nerve surgery or both, we should never be in a position where the wrist extension could be made weaker. And except for very specific cases, there is no indication for respiratory disease in this group of patients. John, this is for you. This is a remembrance from one of the many surgical rehabilitation conferences that were held since 1984. And Moberg should be thanked for that. He was extremely active in getting this group of people all together. And you can see here the name of the past conferences that were done. And this is what I would call part of Moberg's spirit. Because not only did he set all these principles, but he spent the last 2 decades of his life trying to convince his peers, and you must imagine how difficult this was in the time, convincing rehab doctors, convincing physiotherapists that indeed there was a place for surgery. And maybe you can tell us later, Rebecca, but I think that Dr. Gutmann was opposing pretty much that philosophy. It would be interesting to discuss that. Actually, Moberg was also extremely aware of that. He says we could not afford to lose anything. And it was his practical experience that his patients never lost anything, which made him so confident. And I think that we're done. Thank you very much.